Thank you, Fabian. Thank you, Andreas. Thank you, Gerhard, for the invitation. I think it is more than or almost 10 years ago that I was a participant in this course, and you will see in another 10 more years you will present. So I'm very happy to see you all here, and welcome also to the listeners at the screen. So the task I would like to present is the LEMG of the thyroarytenoid muscle. And what Fabian already mentioned is that it is very important to consider the time course of a paralysis. When you decide to perform an LEMG, you have to consider the time point of the beginning of the damage, because this is very important regarding what you can expect from the EMG. Usually, we do not perform EMG within the first 2 weeks. Usually, you have a damage, a surgery, whatever, you have a healing. So there's a high level of discomfort, even from the patient's point of view. After a few weeks, meanwhile, we perform the LEMG after 2 weeks of the damage. After period of time, you can expect the spontaneous activity, you can expect maybe regeneration potentials or pathologic signals, and over time, and this depends on the location of the damage, you can expect synkinetic reinnervation. Of course, if you have a neck surgery, this might happen earlier than in case of have a thoracic surgery. Yeah, so this is very important: time, location, and the interpretation. I heard again the opinion, it is hard to identify the muscle, it is hard to find the muscle. I always say your fingers are the most important supporter, because you can palpate the neck. You have to palpate the neck, you have to find the ring or the shape of the arc of the cricoid. You have to palpate the articulation, the joint between the thyroid and the cricoid. And you can even find easily the superior notch of the thyroid. And if you have these landmarks in your fingers, then it's much easier to identify the muscles. Because direction, position, it is very, very helpful to know the three-dimensional situation of the larynx. If you have a neck like this, then it is very easy to identify the anatomical landmarks. Here it is very easy to identify the superior notch, easily to find the lower rim of the thyroid, the cricoid, and then the cricothyroid membrane. When we do the TA LEMG, then usually we do the EMG from anterior, so we just pass the cricothyroid ligament to reach the TA muscle. To make it more comfortable for the patients, we recommend to take the time for local anesthesia. We inject prilocaine hydrochloride xylanase 2% with epinephrine, or you can even take lidocaine just to give a more comfortable feeling for the patients. The patient will never be free of any feelings, so you cannot avoid little pain if you enter the endolarynx. But because you have to insert the needle usually several times, it gives the better feeling for the patients. So if you have done like this, then of course we start to find the TA, and I would even say TA-LCA complex. It is very helpful if you follow the recommendations given by Fabian and all the co-workers here in this publication in 2012. You did a great job to explain how to localize the TA, the LCA, the CT, the PCA, and also the interarytenoid muscle. And if you follow these recommendations, then you might be successful to be in the right muscle. Sometimes the shape of the thyroid can vary, so you have to even consider the shape and the angle here, how to insert the needle 15, 16, 70 degree, and if you go from paramedian up, or if you go for median more to the lateral part. This is sometimes depending from the anatomical situation of the patient. What is very important and what makes it easier, if you try to stay in the tissue, sometimes you just enter, you insert the needle and you just pass the membrane and then you go back to the vocal cord. Usually this causes a strong coughing. And that's why we usually go a little bit of paramedian position and then upwards. This is more comfortable for the patient and you can avoid the coughing. Yeah, so, and you also have to consider, if you come from here with your needle and you go up, you have sometimes even return the direction of the tip of the needle, because if you want to reach the anterior part of the TA muscle, then you have to go straight up with the needle. Sometimes I even bind the needle so that I have a returning curve of the path of the needle. And if you want to reach LCA, because these both methods can provide different signals, then you go a bit in a different angle to reach the LCA muscle. So, and again, my patient, here you see even sex differences, age differences. You see that the shape can be completely different. I always use this neck because it is so obvious, but I have to mention this was one of my few patients. I could not perform the EMG because when he saw my needle, he collapsed. So, but if you have a neck like this, then you cannot see the landmarks. Here you need to palpate, you need to feel, and you can even do the EMG in these necks. Yeah, but you have to consider the shape, the dimension of the laryngeal skeleton. If you inserted the needle, then you can leave it like it is. If the patient does not swallow, you can just put the needle, take your hands away, and then you try to stimulate the patient to follow your agonistic and antagonistic maneuvers. Fabian mentioned agonistic maneuver for the TA-LCA, sniffing is the antagonistic maneuver. But what is very important, before you start to do any maneuvers, wait and see. Because what is neurophysiologists will always explain, you should wait until you have a zero line of any signals. To get a zero line in the TA muscle is almost impossible. You have a lot of background noise, and if the patient is very tense and anxious, you might have already activation, although he or she seems to be relaxed. But then you have to give time to wait, and sometimes, only sometimes, you can reach the zero line. This is just an example. We use a 3-channel EMG device. The line represents the LEMG signal. The voice of the examiner or of the patient. And the third one is the movement of the chest to consider the breathing.
Nochmal.
We use this type of documentation. Why? Because very often we do the re-evaluation offline. And then you know when the patient was voicing, phonating, when the patient was doing sniff maneuvers. If you just take the documentation from the neurologist, where you just follow the EMG signal, you do not know afterwards what was the maneuver. So that's why we use a 3-channel device. Few more signals, I always recommend don't go directly to the damaged site in a unilateral vocal cord paralysis, for instance. Always start with the laryngoscopically working site. So if you have the feeling that, like here,
Jetzt mal ein A.
Nochmal A.
Yeah, so then you know the direction, you know the inside the way or the centimeters you inserted the needle in, and then you do the same in the opposite way to the paralyzed vocal cord. And what you have heard here is just listen to the background noise, listen to the insertion activity. As soon as you have insertion activity, you have to be in the muscle. And then I start always with the more moderate ah. And if I have the feeling the patient is fine, then I try to go to the maximum phonation effort. And this is what we have to consider when we evaluate the density of the signal. If we say dense, it has to be maximum phonation activity. So, and on the other hand, again, background noise.
Das ist Kontaktivität. Und nochmal A.
And compared with the right side, then you see there is a decreased inference pattern. It is here in this case signal, and this makes it easy. You don't see anything because I stimulate insertion potentials. Then I can say it is silent. And what you also have heard. If you go to the TA left,
Luftraum nochmal tief, Luftraum und entspannen, ganz locker.
In the agonistic and agonistic maneuvers,
Und
agonistic and antagonistic phase gives you then the indication for synkinesis.
Und
Again, the healthy side.
Vorsichtiges A, nicht so kräftig.
You have very tiny activation, but you not activation, the signal is and this is identified. You can also perform the laryngeal EMG in a tracheostomized patient. This is more complicated if you have a high tracheostoma. Then it's sometimes hard to reach the cricothyroid membrane. But I promise, with a little experience, you will reach also EMG interpretation in tracheostomized patients. Thank you.